So what are the questions you're going to ask on this patient? So he's come to the first consultation with the report is pretty asymptomatic at this stage of his life. So what leading questions would you ask him to define his disease more?
Lifestyle first.
Now, let me go through the history. You start always with history. You want to define his disease. He's not going to tell you answer. Like all Indian patient, he will keep the most important symptoms till the last. And he said, I'm all right. There's nothing wrong with me. First of all, avoid death. So you must needle out the cardiovascular symptoms. And then Dr. Mishra and Dr. Virmani will tell us what we would inquire about his glycemic symptoms.
Yeah, exactly. His HbA1c appears to be quite high. So clearly he's uncontrolled diabetes. So we'll ask a few things in that also. One is something regarding diabetic neuropathy. Well, especially does he get tinglings or something like that, or pinpricks, or is asymptomatic, or is any other?
His blood pressure is this, as you were asking. His glycemic hemoglobin is slightly better, but this is his lipid levels. His creatinine is at least reasonable. Now, just have a look at these figures, and the next question would be his cardiovascular risk. What would you consider his cardiovascular risk? I want someone from the house. High, low, intermediate.
High.
Okay. High. Anyone else differing from that? So every one of you, I think you're right. But it is often we underestimate cardiovascular risk. In this case, it is high very clearly, but we often underestimate cardiovascular risk. And sometimes this is a picture, this is a very good Scandinavian study which shows that if you use a risk calculator, a basic risk calculator, either the Framingham or the European, you are actually better at it. If you see, this is the perceived risk by a GP without using a calculator in each of these patients. So if you see, this is a 61-year-old man with smoker, LDL was this and this. The perceived risk by his physician was 10%, but if you put that onto the risk calculator, it is actually far higher. So what is always apparent in cardiovascular risk is usually higher. This is actually a very pertinent slide that we, most time, we underestimate cardiovascular risk. So this is the two risk calculators we use. This is the Framingham one and the Euro one. So we have that in the choice, but out of this choice, because we are now assessing a little bit of cardiovascular risk, we are gearing onto the cardiovascular risk now. What are the investigations? What choice would you do here? Beg your pardon? Who would do homocysteine? Raise? Okay, fine. Anyone else? Is that enough for a cardiovascular risk in this 39-year-old male with host of risk factors? So, what would you do? A stress TMT, a CT angio, or a coronary angio? 39-year-old man. Okay? What stress? Stress? I think stress TMT. A 39-year-old man, if you look at the Bayes theorem, his probability of coronary artery disease is very high. So he is going to have an excellent specificity with treatment test. Simple test can be done, not expensive, no radiation, no invasive. So a simple TMT.
There is a controversy, I beg to differ here, because asymptomatic, ECG normal, should you really go for stress TMT? There is a big controversy going on.
Nah, yeah. I will
because otherwise you create cardiac neurosis.
No, the reason I'm telling you, he's feeling tired. He's not actually asymptomatic at this stage of his disease. If you see the previous,
Stress can be because of many reasons.
It can be, but what will kill him is a coronary event if you have not predicted it. The prediction, if this was a lady, 35 or 40-year-old lady diabetic, then your TMT would be really not very contributory. But you have to tailor it to the patient. A 39-year-old male whatever the guidelines say and whatever, you don't need anything very invasive or stressful. A stress TMT is good enough. And if it's clearly positive, I think you have to target that. Because you have to remember, in diabetic, 25% of coronary artery disease will be asymptomatic to start with. Okay? So he did a TMT, and this is the TMT result. The Bruce protocol, 9 minutes, managed 86% of heartache. He had angina, but this was non-limiting. Now here is it. He had angina, but he could walk to it. That means it is non-limiting. And he had an ST depression of 1.5. So clearly a positive test. So from the cardiovascular point of view, the next question would be, what is the risk prognosis of this patient? High risk, intermediate risk, low risk. Can we calculate that from the TMT? So let's go back to the TMT. 9 minutes on the Bruce protocol. Achieved fairly good. If you have achieved 85%, it's an adequate test. He had angina, so it's very specific now. And it was non-limiting, and the ST depression was significant, more than 1 millimeter. So anyone wants to guess what kind of cardiovascular risk would you put this patient on to?
High risk.
Okay, so let us we have an excellent calculator now, and it's the Deep University scoring system. Sorry, it is exercise time. That is the major indicator. If someone has exercised more than 6 minutes on a Bruce protocol, cardiovascularly he cannot be too bad. That's the bottom line. Forget about anything else. So if he's managed 6 minutes on a full Bruce protocol on a treadmill, cardiovascular, he can't be bad. So exercise time minus 5 into ST depression, which is 1.5 in this case, and 4 into angina index. Angina index is 1 if it was non-limiting. The angina was there but did not stop it. That is called non-limiting angina. But if the angina was so severe that he had to stop doing the treadmill, it's called limiting angina. So if it's non-limiting angina, you give the angina index as 1. If it's limiting angina, you give it as 2. So in this case, he managed 9 minutes, minus 1.5, so he had a score of minus 3.5. In the Duke scoring system, he is extremely high risk if the score is less than minus 11, means more negative. On the other hand, if it is more than plus 5, it is low risk. So this guy falls into the intermediate risk from the cardiovascular risk point of view. So from even a simple treadmill test, you can actually sort of postulate a lot. Yes, not that definite, but good enough actually. This is very well documented, the study and we regularly use this now. It's been put into protocols in almost all TMT machines. So we would use an antiplatelet. He's in a high risk, a diabetic. What antiplatelet would you use? These are the choices: aspirin, clopidogrel. He's got established arteriosclerotic disease. He's got diabetes. So what are the combinations would you use? Would he, number one, would he use a single agent or a double agent?
Double agent.
Why?
It's a high risk. He is not TMT positive. So
I think,
and he is also diabetic. So better to put him on drugs.
Should not be misused.
I fully agree.
Dual
antiplatelet therapy has only 2 indications: if you have stented the patient or if there's an acute coronary syndrome episode. PCI cure for acute, even if you haven't stented but he had a myocardial infarction or an ACS, we have the PCI cure study to support dual antiplatelet. Or stenting, of course, will use any of these dual antiplatelet. Beyond that, if you have stable coronary artery disease, this is called stable coronary artery disease, you would use a single antiplatelet. Aspirin in all cases. If intolerant to aspirin, you would think of clopidogrel. Pasupril and ticagrelor do not have data for chronic stable disease. These are new molecules coming off the block, and a lot of people will make a lot of it. But in stable disease, you do not use the more powerful, the risk-benefit ratio between prevention of cardiovascular events and bleeding is not balanced out in chronic stable angina. So that's important. So coming to this lipid, only one slide about lipid. So here's your choice.
Sorry, that aspirin, how much the dose should be?
75 to 325, that's the dose.
But I 25.
I use 75 to 135.
This is more of a primary prevention than secondary prevention.
I would be comfortable with 75 or 150.
I think 75 is good enough.
I would
You
agree.
really want to give.
There's no data to support that the higher dose is more effective, actually. So, lipid, you saw the lipid levels. He has some amount of disease. So, what dose of statins would you use? Here's the options. See? Why see? So I think your C is right. You would used to have a high risk. Because it is a high risk and because he has now atherosclerotic disease. So if we go on to why, this is the algorithm now, which is very well established. Never mind that you see the LDL cholesterol doesn't come too much into play if you have already established atherosclerotic disease or extremely high risk diabetic patients. So here we are, probably we are here. So we will have to use a statin dose which will actually reduce your LDL cholesterol by at least 50%. And that only will be 80 milligrams of atorvastatin or 40 in certain cases or 20 and 40.
Can I just add one more thing?
Yeah.
Absolutely fine. But if you see the recent Indian lipid guidelines, all diabetics have to be put on moderate to high intensity statins unless the risk is less than 7.5%.
That's what absolutely.
So Indian lipid guidelines now clearly say all diabetics on moderate to high intensity statin. As simple as that. And with such risk factors as smoker
And he's got a positive
and
PNP.
positive family history and whatnot, he has to be on moderate to high
So
intensity.
40 to 80 milligrams of statin. Okay?
How long? Suppose we start this patient on 80 atorvastatin.
Now, this is
How
a-
long will continue?
Yes. Now, I think between 40 and 80 is less controversial. I don't mind that if you after 6 months you reduce it to 40. But really you do not have data to go beyond 40 and below. The reason is you're not only targeting LDL, in fact they are saying in the recent guideline, do not even measure your cholesterol in atherosclerotic disease. You just want to give statin like you gave aspirin. Do you measure anything while for giving aspirin? You don't. So for statin, high dose statin in people with established coronary artery disease, actually there's no use of measuring your cholesterol every 3 months.
Only thing is that you reduce the base level by 50%.
Can I add something?
Yeah, sure.
If you analyze reducing what reduces how much atherosclerosis and coronary artery disease like hyperglycemia, hypertension and statin. Hyperglycemia controlling diabetes is not even 20%. Very easy. Hypertension almost similar. But giving statin
Absolutely. I'll come to that slide later. I've got your slide exactly there.
more than 70%.
Absolutely.
It should be used.
Absolutely.
Absolutely.
And in fact, I was coming to that later. So here is, this is why I will deal. So we have finished with the statin, no controversy at all that we have to have a moderate to a high dose statin, yeah? And then we target the blood pressure. Now this is the blood pressure and this is a problem. And the Indian problem, let us see the Indian problem. The prevalence, this is the recent Indian data, very, very worrying. 1/3 of rural population are hypertensive, a little more than 1/3 of urban population is hypertensive, all Indian surveys. So this is very, very high incidence of it. And look at this data. Prevalence of hypertension is 1/3 in the population. People aware of their hypertension status is actually just about less than half in the urban and less than 1/4 in the rural population. Hypertensive being treated is again 1/3 of what you have detected, and actually proportion who have blood pressure controlled by recent guidelines, which are again contentious, and we can go into those contentious issues a little bit, is just 30%. So this is the real problem of Indian hypertensive, and this is where generic drugs, innovative technology absolutely affordable, good medicine. That's the two. You have to have affordable, but you cannot compromise quality. The quality has to be international standard, and you have to have affordability to have even basically a farm shop owner in a rural practice having to have one tablet a day. You have to have compliance. You cannot have very complicated regime with your patients. Either you have to have combinations, or you have to have long-acting drugs, which is going to give him control throughout the day. So that is the challenge of India. So let us see the guidelines. This is where I get confused also. Recent guidelines with hypertension is very, very confusing, and that is even more sort of confused by the recent trials which have come down. So, contrary to the previous guideline, they have actually liberalized your blood pressure regime. So, 140 by 90 if your patient is less than 60, this is non-diabetic for all the patients. And basically 140 by 90 for ESC, more or less agreeable. What I also want you to do is note it here that beta blockers unfortunately has fallen in all the three guidelines except the ESC. The ESC is again not challenging the beta blockers. I'll deal with 2 slides on that as well. So the blood pressure regime has become a little bit more liberal. So 140/90. And why has that been so? So this is the Indian hypertensive guidelines which has come up. If you have a young patient, you start with either an ACE inhibitor or an ARB, or a beta blocker only in special circumstances. If you have coronary artery disease with hypertension, beta blocker. If you have people with white coat hypertension, stress-induced hypertension, then you would think of a beta blocker, not otherwise. In the elderly above 60, a CCB or a diuretic would be your first line. So this is where your choices are. Absolutely. Thyrotoxicosis is another good for beta blocker. And then you do a combination. How many of you use aldactone or spironolactone as a management strategy for your blood pressure? Absolutely excellent. Take it from me. I actually bring it before the ulcers occurs. And the only thing is in males you have some amount of gynecomastia developing. That's the only bad part. But it's an excellent antihypertensive state. So third line agent spironolactone is worth thinking. Now, one thing very, very good, the regime is it's up to you to decide. It's not a very rigid regime. These are suggested regimes, and you can use any drug which actually controls your blood pressure. The control of blood pressure to target levels is much more important than what class of drugs you use. That is the bottom line. And let us see. It's always metoprolol or another thing. So the newer beta blockers, especially the vasodilator, may be an option, nebivolol, in those young group of patients, labile hypertension, white coat hypertension, thyrotoxicosis, they will have better side effect regime profiles. So, but recent.
I think they are good for elderly also. Vasodilating properties.
Yes, in the but elderly, I would first start with the calcium channel blocker indirectly, because the reason is in the younger patient, hypertensive, what complication do you want to prevent? You want to prevent cardiovascular events. The best data is with ACE inhibitors. On the other hand, in the elderly, what event do you want to prevent? You want to prevent strokes. CCBs and diuretics have the best data. So that is my rationale of dividing the therapy as the initial part. Then you mix it up. That's fine. Now, let us go to 2 studies which have actually churned up, these liberal sort of 140/90, everyone in diuretics actually had an adverse outcome. So they carefully excluded diuretics. And what they found out, that if you have a regime which controls the blood pressure between 140 and 120, so 121s did better. So again, reverse the concept of that, you go lower than 140. So this is the confusing bit. So the SPRINT trial has said, you combine the tablet, and if you have a non-diabetic person without established coronary artery disease, you can actually go to 120 because that has shown to decrease events. Unfortunately, things were not that simple. The only problem with this high aggressive regime with some amount of renal dysfunction which you expect. If you are using high dose of ARB, if you are using high dose of ACE inhibitors with diuretics to reduce the blood pressure very aggressively, it is intuitive, theoretically intuitively correct that you're going to increase your renal dysfunction. So, sprint study conclusion, in all these age group, intensive blood pressure lowering exceeded the potential for harm.
But in diabetes, we like to have blood pressure somewhere around 130.
We'll come to that. I'll slowly developing that. Unfortunately, the HOPE-3P blood pressure trial did not find that out. This is again another recent trial. Again, this with intermediate cardiovascular disease, with risk for cardiovascular disease, with normal or low BP. Low BP means basically 120 level, normal means 140 guidelines. And they used hydrochlorothiazide with an ARB. Candesartan is an ARB. Unfortunately, the curves actually did not separate. So there was no difference in outcome, a little bit contrary to what the sprint data was showing. The only person who benefited slightly was actually on the higher blood pressure. So it comes back to that probably with the present data, this 140-90 or 140-85 is probably rational. So even with the sprint data coming along, I don't think the time has come to go lower and lower, lower and lower.
Have you gone through the post-analysis of the sprint data?
Yeah, I'll come to that. Yeah. So, HOPE-3P, this was the comment of the HOPE-3 trials that are finding lower is better hypothesis. So that is not tenable, and a systolic blood pressure of 140 seems reasonable target to achieve. Now what do we do? So in hypertension cases, this was the Accord trial which actually put the first brakes on that lower the better. The Accord trial showed that actually 140, if you target to 140, diabetic patient to 140, they are better off. There was no difference in outcomes. Not only that, if these diabetic had coronary artery disease, actually 120 was deterrent. You decreased coronary flow. You had more cardiovascular events. So if a diabetic has coronary artery disease, lower the better does not stand. So I won't go into the details of the Accord study. So look, this is again coming back to the regime. So in the diabetic, everyone nearly agrees that 140-90. In the ESC guidelines is 140, subtle differences. The only qualification, if you have proteinuria, you would target it 130. So I think this is where the ACR and the proteinuria, and I think this is a very reasonable. The ESC guidelines makes more sense to me than the American guidelines, where they are much more rigid. This makes theoretical sense that if you have kidney injury, if you have mitroalbuminuria, then also the kidney, the nephrologist data also would suggest that. So I think that is right. For most people, 140-85 or 140-90 is acceptable even with diabetic, but if you have proteinuria, you target it a little low. So this is the KidCo data. So 130-80 if albuminuria is present. Dr. Virbani, you were saying about the sprint data?
What I was saying is, the sprint trial that initially came out showed hopes that if you get the blood pressure down to less than 120/80, you have improvement in cardiovascular outcomes. On the analysis, it was shown now how they have checked the blood pressure. How many people here know how the blood pressure was checked in the sprint trial? Anybody knows that?
Automated.
Yes. Automatic. Patient was resting in a dark room for half an hour, and he was, in the last 5 minutes, he was not allowed to talk, and a digital recording was done. And then also they achieved the blood pressure of 123, not less than 120. Now, if you compare that with your clinic blood pressure, that 123 is as good as 140.
Absolutely right.
So they said, these are the caveats with the sprint trial. So let us not take it, let us take it with the pinch of salt.
That's why the Hope trial, where the blood pressure was much more liberal, what was similar to what we do in practice.
But Hope 3 had another caveat, the positive side. The positive side was that if you give a statin to a low-risk hypertensive patient, you reduce the cardiovascular.
That is what I am going to.
There the stress was more on statin rather than on the oxygen control.
So then, coming back to Mr. Kumar, he is lost to follow-up, and then he comes back to you 4 years later, and now he was swearing that he is taking no other medicine except those prescribed by you, but he hasn't seen you for 4 years. He has reduced smoking, so he hasn't stopped, and stopped regular alcohol use. His osmotic symptoms, he however has osmotic symptoms. He now gets overt chest tightness on going up the stairs and also has a tired leg on walking. So he now clearly has established cardiovascular and peripheral vascular disease. His blood pressure is better, not the targets. Glycated hemoglobin, again not the targets. Cholesterol, not the targets. Better. Creatinine, fortunately for him, has not deteriorated too much. So, in coronary artery disease and diabetes, out of the three, Dada was telling us, which would be the most important to control?
Hypertension.
Dyslipidemia, actually. Cholesterol, I think he actually put it on. Cholesterol will contribute nearly 60 to 70% of the coronary vascular disease. So there's a clear description between macrovascular complication, where cholesterol and secondly hypertension is more important than glycemic control. The reverse is true about microvascular complication, where glycemic control will place the upper hand. So this is the what we call the duality of diabetic medicine. So diabetic sugar please is not only about controlling sugars. It's much more than that actually. So this is microvascular and what we have got through. So now let's quickly go through the chronic stable angina. So this is the last part of the side. So beta blockers, angiotensin converting enzyme you would give. This is a quick question. This is on recent data. Does beta blockers prevent even unstable angina? No. Beta blockers' role in stable angina is only management of symptoms. It is only in post-MI or LV dysfunction that beta blockers will decrease mortality. So, if you
only for the first month,
yeah,
not after that.
not absolutely right. The problem with beta blockers, a lot of people do not tolerate beta blockers, and if they have chronic stable angina, do not be shy of using diltiazem or anything else, which is probably sometimes better tolerated. So it's not sacrosanct that you have to use beta blockers in stable coronary disease with an intact LV function. Let me qualify that. The moment you have LV dysfunction, beta blockers is going to come much more important. Because we know now LV dysfunction and heart failure, beta blocker is very, very important. So I will not go into the data, this is very well known. So again, this is beta blockers, calcium channel blockers and nitrates, the guidelines. What we do now for management of angina, be a rate limiting agent, beta blocker or a diltiazem. Here things have changed. We do not use long acting nitrates anymore. We bring in either ranolazine or nicorandil into that second step and keep nitrate only for an SOS, just to spray for symptom relief. Rather like asthma, when you spray your salbutamol only from symptom relief, not to prevent recurrences. Okay? So, what further would you do with this patient? So here's your question. Would you go for CAG and PTC or would you defer? He's symptomatic. You started in medical therapy. Would you do an angiography? Contentious. Okay, I'm an interventionalist, but I wouldn't do coronary angiography at this stage. The reason is we have the courage data which show that if you interfere in stable coronary artery disease, let me qualify this very, very clearly. stable and unstable angina is two different disease processes. The biology is totally different. It's not about the narrowing of the artery, the biology of the disease is different. So if you have myocardial infarction, ACS, unstable angina, intervention at the first go. If you have stable disease, actually like this man has, actually whether you intervene early or late actually does not decrease mortality. So this is important. So you want to defer till you have given anti-anginals a very well good. But during the history, if he suddenly comes to you and says, I'm having rest pain, you would go immediately in. That is unstable. The biology of the disease, the plaque morphology or the biology has changed. And then intervention becomes foremost.
Even in stable angina, despite having used beta blockers, calcium channel blockers, nanosyn, if he becomes symptomatic...
I'll come to that. That's exactly my point. This is where, okay, he's symptomatic with 3 anti-anginals, so that's where I would do an angiography, but I've given anti-anginals a good chance. I would not hurry into it, okay? So, and this is his angiography. So, this is the left main stem, this is the circumflex, so you can see the block unfortunately is about 70% here. This is not one of the greatest view I've been able to pick up, but this is about a 70% block. Would you stent it or not? 70% block, anginal symptoms. Mind you, he's a diabetic. You have to also think of small vessel disease.
But there is no diffuse disease as such.
No diffuse disease. No diffuse disease. So it's no, you won't go for a bypass. Would you intervene at that? Absolutely, that's right. You do not intervene without an FFR. So PTCA, yes, no, not sure, more evaluation. I think this is your choice, more evaluation. And this is what we do in our labs, is an FFR where you measure the pressure before the block and after the block with the coronary pressure wire. All cath labs, FFR just cost is very little, it's 5 lakhs, some instrumentation. If they're intervening in chorionic stable angina, you must check your FFR, unless the block is clearly above 90%. That's a different story. Intermediate disease, 70-80%, never interfere. And if your FFR is not below 0.75 or 0.8, you do not have the right to interfere. In fact, this is the data from the FAME study, which showed that if you used FFR and angio-guided, the FFR group did very well. You selected, you used lesser stents, you stented lesser people, but actually your outcomes were better. So, does PCI in stable coronary artery disease decrease mortality? This is my final question. In stable coronary artery disease, mind you, I think yes and no. Say, if you asked me this question 5 years ago, I would say no, with the courage data. But this was the FAME 2 data, which said that if you did your FFR, and if your FFR was strong, and if you are only intervening in FFR positive, you decrease mortality. So
If FFR was
positive.
Yes, that's there at least.
Okay? So thank you for this. Any questions? So I thought could I sort of...
Have you passed? Have you passed your exam?
Every one of us has. It's a challenge for all of us. Medicine, this is why you like medicine. That is why you start thinking. It's not only everything is in the books.
Can I have one?
Yes, sure.
Test committee. So there are less than 200 patients, and the control, they even didn't bother to check the blood pressure. And those who were treated had to have diastolic blood pressure of more than 110. Systolic was not considered at all. Even then, they got benefit from the control and those who were treated. And now we have so many trials.
If you look back even further into the 40s and 50s,
so many trials are now. And it is important that you select the case properly, as you have shown in. Like ACCORD trial was prematurely withdrawn because of the increased mortality, cardiovascular mortality. But those who continue, they have shown reduced microvascular complications. So a patient who do not have atherosclerotic heart disease, who want to reduce his blood pressure less than 120, the eyes will be saved, kidney will be saved. So it is, as you have shown rightly, the risk estimation and proper patient selection is mandatory before, and we have so many drugs. At that time we had Ramchial. When I started my internship in 1970, my boss used to give phenobarbital as antihypertensive. He said it is as good as Ramchial. Patient will sleep and blood pressure will come down. So that was the situation. Now we have so many drugs, but proper patient selection is very important. Otherwise you cannot use the proper weapon. Thank you.
Thank you, sir. Thank you so much.